Hello, this video is on the new patient interview, the new patient examination, and then the final one will be on the new patient consultation. These are critical if you want to have a comprehensive practice. I can tell what type of examination a dentist does if I look at their book. If they're seeing a bunch of little niblet things like a filling here and a crown here and a filling here, I know that is a patch-up practice, a toothache practice. They see a patient, they've got an issue, they treat that issue, they go home, they have another issue the next month. What I'm talking about is a comprehensive practice. So I don't do patch-up. I support patch-up practices. There's a place for that. Practices that just put in big fillings, patch teeth up, kicking the can down the road. But at some point, if the patient lives long enough, they're going to have a problem that's much worse if the teeth are not restored optimally. Though this is a new patient, she's a 20-something-year-old girl. I had spoken with her dentist where she was from, out of state, and he said she's got train wreck. So what I'm showing you is the value of an initial new patient interview. I want to know who's connected to the teeth. I want to talk to the patient ahead of time and find out, why are you here? How do you happen to be in my office? If they just wanted a dentist near their house or picked a dentist out of the phone book, I know that this patient is probably not going to want what I do. And I'll tell them that at the interview. I'll say, you're a good person. I hope you think I'm a good person, but I don't patch teeth up. And if you don't know anything about this practice, you probably should leave right now. I don't even want to take your money for an examination because we're not going to do it the patch-up way. We're going to fix it, even if we fix it in stages. I don't patch it up because then your problem becomes my problem when I patch up a tooth and you break that tooth and you say, you just fixed that tooth. No, it wasn't fixed, it was patched up. I've never wanted to deal with that, but at my stage of practice, I certainly don't want to deal with your problem becoming my problem. I'll fix your problem, but I'll fix it an appropriate way. So I take these 12 photographs of every new patient. That's a full face, then a smile, then lips in repose to see how much incisal edge is displayed with the lips in repose. Then a retracted view of the anterior teeth closed, a retracted view of the anterior teeth open. You can see all the hypocalcification and the decay on the facial surfaces of the teeth. Now, by the way, as dentists, we can tell a patient's eating habits by where the decay is, what kind of sweet they're eating. If they have decay in between the teeth interproximally and on the occlusal surfaces, you know they eat sticky sweets. Gummy bears, Jolly Ranchers, Snickers, Milk Duds, that kind of stuff, because those teeth decay interproximally and on the occlusal surfaces of the teeth. They probably didn't have proper sealants when they were a child, and they're eating sticky sweets. If there's decay on the sides of the teeth, or this hypocalcification, that's some kind of a liquid sweet, like sucking on cough drops or sucking on mints, drinking Coca-Cola. Coca-Cola and Mountain Dew are like battery acid with sugar in it. So I can tell with this hypocalcification, this is beginning decay on the sides of the teeth. This has already gone through. This is decay. This is going to be decay. And then we've got occlusal decay too. So she was doing everything. You know, eating, you can see this tooth, remember decay in the occlusal surface is like a termite. It makes a little tiny dot in the occlusal surface. You know how a termite makes a small hole in the wall and then it blows up once it gets inside. Well, that's what decay does. And so it makes just a little tiny hole in the enamel because it doesn't want, the bacteria doesn't want the enamel, it wants that dentin. That's the chocolate pie, that's what it's after. So it makes that little tiny hole in the enamel and then gets in the dentin and just blows up. You can see all this darkness around here. These teeth are not decayed occlusally. These are the anterior teeth. Then this kind of stuff, see all that dark shadow underneath it? You know. So that's, if it's occlusal or interproximal, that's something sticky. Twix, Jolly Rancher, Gummy Bear, Snicker, caramely, and throw in don't floss your teeth and don't take good care of them, you're going to have occlusal or interproximal. You got this old bar. Remember, we're like detectives. And this comprehensive exam is so much fun because it's like being Sherlock Holmes. And you're gaining evidence, and then you sit down and you look at these photographs and radiographs with the patient and discuss the situation. Now look at this. We're going to look at these individually. She's got decay between every tooth in her head. All right, this is the upper right posterior, and you can see there's been some patch up done on this tooth, but you can see there's interproximal decay between all those teeth. This is into the dentin of the tooth. See, it looks like an upside down pyramid or triangle. And so these are all decayed into the dentin of the tooth. Again, decayed into the dentin of the tooth. All these through the enamel, into the dentin, interproximal decay between every tooth in the head, okay? You saw the facial decay on those diagnostic photographs. This is the upper left. That's the cuspid first molar between every tooth in her mouth. See, this tooth is just rotten up here, upper second molar. You remember when we looked at the photograph of that tooth, it had that termite hole in the top and then just all that dark around it. So all this is decayed away. Then we've got these big interproximal cavities. You remember you can only see about half of the amount of decay on a radiograph, only about 50%. So whatever you see here, there's 50% more than that in the mouth. And couple that with the decay you saw on the facial surfaces of the teeth. These are the upper anterior teeth. See decay here, just not so much decay here, but significant decay here and over here, decay here. This is the upper left cuspid. And then the lower teeth, you can't see, they've got decay here too. And of course, when you've got these lingual bars, I find it interesting. I love orthodontists. I mean, I love orthodontists. I hate these lingual bars because they put those lingual bars on and they never tell the patient to take them off so they can't floss their teeth. So they get, over time, gum disease, they collect food, plaque and calculus built up, decay between the teeth. The reason those lingual bars are on there, and I would have done the same thing if I was an orthodontist, I would say, I'm sick of these kids not wearing their removable retainer, so I'm going to fix them. I'm going to put that fixed bar on there so that they can't not wear it. But the problem is they don't tell the kid, you've got to floss underneath this. They're probably not going to do it, or at least use a water pick, and you need to take this off and get a removable retainer several years down the road. For retainers, what I like is a proper occlusal orthotic appliance, a centric relation occlusion, flat plane, hard processed acrylic night guard for the upper teeth. That also keeps patients from wearing their teeth away. On the bottom, I like a removable wire acrylic retainer that's not on the occlusal surface. These vacuform retainers that orthodontists make, they're easy to make, but the occlusion is often not right. So if the occlusion is not right and the person's grinding their teeth, that's a good way to develop myofascial pain and intra-articular or TMJ problems. All right, so we got all this decay between these teeth. It's not so bad. And now Pantograph is not going to diagnose decay. It's too broad. It'll diagnose wisdom teeth, pathology, different things, but it's not going to diagnose decay. You've pretty much got to have periapical radiographs and bite wing radiographs to diagnose decay. This is what I do at the interview. I write down what the patient tells me. She said she had sensitive teeth. She had been told by their other dentist she had decay between the teeth, and she took drugs in high school and had an alcohol problem. So I know that going in. I want to know who's related, who's connected to the teeth. It makes dentistry so interesting because it's more than just fixing teeth. It's a relationship situation. Who's connected to the teeth? Who are the players? Are you paying for this yourself? Are your parents involved? Is your spouse involved? You know, I always want to know that, because I want all the people that are involved in the finances to be in on the consultation. I won't do a consultation if everybody involved in the finances is not in on the consultation, because I'm going to show them photographs of their teeth. We're going to look at these books, so when they see decay, they've seen the books already, they know what it looks like, or cracked teeth, or abfraction, or big fillings, or whatever it is. And then I've also got restorative dentistry in these books, so they can see what veneers look like in different situations. You know, or periodontal crown lengthening with veneers, all kinds of different things. We look at these first. You don't have to use these books, have something else, but you got to have something so the patient and whoever's involved in the finances can see what pathology looks like and what restoration of a not optimal situation looks like. Then you look at the photographs of their teeth. Okay, so I write this down. This is what she's telling me. Then we do the comprehensive exam, and this is what we found: decay between all these teeth. That's what you saw on the radiographs. We write that down, and then I'm going to have the pulse and the blood pressure, any notes I want to make, and then I'm going to have a separate consultation. I don't do the consultation at the new patient exam appointment. At that first appointment, I have an interview in my private office, not in the operatory. The operatory is a scary place for a patient. I want to have it in my private office, which got family pictures and pictures my grandkids and our daughters have drawn, and it's a friendly place. Then we go back and do the new patient exam, which involves full mouth set of periapical and bite wing radiographs, a comprehensive exam of everything: bite, gums, lymph nodes in the neck, periodontal issues, decay, existing restorations. We do the comprehensive exam. Then I take diagnostic photographs of the teeth, those 12 photographs. So what we've done so far, we've had the new patient interview in my private office, and they go back to the operatory, and my dental assistant takes the full mouth set of periapical and bite wing radiographs, and she does the initial comprehensive exam. She's been working with me for 40 years. She knows how to do that as well as I do. Then I come in and take the diagnostic photographs. There's 12 of them. You can look at the video on photography at the dental examination. Then Pam and I do the co-diagnosis. She goes over what she saw and calls it out to me, and I'll say, yes, yes, what's that, or whatever it is. In other words, it's powerful if a patient can hear it from two sources. They're hearing it called out. They're using these different senses. Number one, Pam's looked at it. Now she's calling it out to me, so they're hearing what she's saying, and I'm confirming it or I'm commenting on it. We're writing this down, and then I'll make myself notes up here. In my practice, you don't have to do it this way. I'm not going to put fillings on all those teeth with decay. They're not going to hold up. Remember, the coefficient of thermal expansion of a composite filling, how much it expands and contracts when exposed to hot and cold, is 75 to 80. A tooth is 10 or 11. When a patient drinks hot and cold, that composite filling is going like that, and the tooth is going like this. Why do you think all those composite fillings, especially the big one, because coefficient of thermal expansion affects a larger filling more than a small one, why do you think they're all stained, pulled away from the margin? Not to mention the fact it's really difficult to get a sealed margin on an interproximal subgingival composite filling for a million reasons. I don't do big composite fillings. If they're big like that, I'll tell you what we're going to do here in a moment, but you can decide how you want to treat them. So all this is going on. So I'm saying this is either a full mouth reconstruction or all on four. These are notes to myself. So when I do the consultation, I've got notes on what I'm thinking when I looked at the radiographs and diagnosed the patient. So my assistant takes the periapical and bite wing radiographs of the teeth. Then I come in and take the diagnostic photographs of the teeth, the 12 photographs, and then my assistant and I go through her findings. When we look at the consultation sheet, you'll notice I write on there, please get a second opinion. I'll work with any dentist and send them radiographs and photographs to make you comfortable with what I'm talking about, because when I do these kind of diagnoses, I'm deciding, do I really want to do the case or not? This is a complicated, involved, expensive case. Okay, so this is the TMJ findings. Then a periodontal exam. Okay, so now I know what we're looking at. I've looked at the radiographs, I've looked at the patient. So I'm going to push back in my chair and I'm going to say, where are we going with this? You've got a train wreck. I said, it's like a house damaged in a hurricane. Carpet's soaked, the hardwood floors are soaked, the walls are soaked, the roof's blown off. You could save the house, but it's going to be very involved, very expensive. Or you could take 3 bulldozers at the curb, knock it down, and start all over. That would be like an all on 4. So our options are to restore these teeth with periodontal crown lengthening surgery, endodontics, crowns, veneers, etc., maybe some teeth extraction, or, which you hate to do, this is a young person. You hate to extract all the teeth and place all on 4. But from a practical standpoint, I can't do it for free. I'd go broke. I see quite a few of these cases. And so you want to be reasonable and give the patient some options. We do quite a few all on 4s that they're just so extensive. There's so much decay on the teeth. There's so much restoration that it's not practical. I want to go to the end and work backward. How is this going to end? So that is my conversation with her, just to give an overview. Since this was a young person, I'd had her permission to talk with her parents on the phone. She was from another state. And I asked them, I said, look, you're either going to put a really nice car in you're going to put a car in your mouth any way you go, but you're going to put a really nice car in your mouth if we restore the teeth with periodontal surgery to move the gums down on the lower teeth and up on the upper teeth, remove some bone, and get a clean slate so we can restore the teeth, or we can extract all the teeth and place all on 4, which I don't want to do. I work with an oral surgeon on that, but that is an option. And that's our job right now. We're not trying to sell anybody anything. The word sell has no place in healthcare. I want to give this patient and her parents an accounting of what the dental condition is and what the options are. Depending on what the situation is, somebody may have a couple of fillings, or they may want veneers, or they may have decay between their teeth. They may not be a full mouth reconstruction like this. I'm not going to talk about it definitively, but I'm going to give them an overview. And I'll say, where do you want to go with this? And they'll usually say, well, what would it cost? And I'll say, you could put, if you fixed everything, you've got 2 parts. You've got the pathology and you've got the cosmetics. Now, if you just fix the pathology, say you replace missing teeth with implants or fixed bridges or a removable appliance, and you just place crowns on teeth that have broken big fillings or whatever it is, I said, you could probably put a Ford in your mouth, or you could put a Mercedes in your mouth, or you could put a used car in your mouth, just something that they can relate to. And if they say, ooh, I don't want to do anything like that, say, well, let's talk about if I can get you where you want to go, because if they're just wanting somebody to put big fillings in teeth that have interproximal decay, I'll say, I'm not even going to charge you for this exam. We'll send the radiographs wherever you want to go to someone who will do what you want to do, because I don't want to do that, because then that's going to, most of the time, that's going to break down, and now we've got another problem and an emotional issue, because you won't remember that we talked about this when those teeth broke down, that they just were patched up, and you'll think, you just fixed that tooth and it's broken, or it's leaking, or it's decayed, or whatever it is, because those big fillings won't hold up. So that's what I do, just the overview between the yellow lines. Where do you want to go? We decide if we're going to go on with this and go through a consultation, and I say, I don't want to spend the time and I don't want to take your time on a consultation if this is not going anywhere. If I'm not going to be the dentist that does your treatment, I'd like to help you get to a dentist that wants to do it the way you want to do it. So I'm really qualifying the patient once I've looked at their radiographs and looked at their teeth, and just give them a general idea. Then we set up the consultation appointment. So leaving the exam, they have an overview, yellow lines of kind of the general treatment and the cost. And they know that anybody involved with the finances must be at the consultation appointment, either on the internet or in my office. And we actually have them sign a sheet saying anybody involved with the finances must be there. There's no worse feeling than having a patient leave a consultation and saying, I need to go talk to my spouse. Well, the spouse wasn't there to see the books, to see the photographs, to see the radiographs. All they're hearing is the cost. I don't want to deal with it. I don't want to go through it. It takes me probably anywhere from 30 minutes to an hour to put a consultation together, plus they've got an appointment or an hour, and I don't want to deal with it if it's not going anywhere. I want to help them get where they want to go. So that's the end of the examination appointment. So if the patient is a go so far, we schedule a consultation appointment.